Ma'am, I'll start.
Very good evening to all of you. Yeah, I would request Dr. Shefali to welcome Dr. Mona Gajre.
Good evening, respected doctors, and welcome to the second episode of Brain Mantra, our webinar e-series on developmental disorders by Dr. Mona Gajre. I take pleasure in introducing the eminent speaker for Brain Mantra, Dr. Mona Gajre. She is a practicing pediatric, neurologist, epileptologist, and developmental disorder specialist practicing at Dr. L.H. Hiranandani Hospital, Powai, and Surya Hospital, Chembur in Mumbai. She is also a full-time professor of pediatrics at Lokmanya Tilak Municipal Medical College and General Hospital, Sion. Over the years, she has done various roles with teaching experience of 26 years. She is a member of Indian Academy of Pediatrics, Society of Developmental and Behavioral Pediatrics. So, the topic for today is autism diagnostic tools. So, without wasting much time, I would hand over the session to Dr. Mona. Good evening, ma'am.
Yeah, good evening, Dr. Shefali. Thank you for your kind introduction. I hope I'm audible, loud and
Yes,
audible.
ma'am. Yes,
Yeah,
ma'am.
great. So
Yes, ma'am.
if I can have my PPT open, is my PPT there? This is the PPT.
Right.
Is it open?
Not yet, ma'am.
Okay, great. So today we will be talking, this is the second of the series on autism. Last time we had a talk on what were the early symptoms and signs of autism. And we talked about why the need for detecting autism earlier on. The simple reason being that the earlier that we pick up the autism and we institute therapy, the outcomes are very good and much better than starting therapy much later. So, as we saw in the last presentation, that the autism or the symptoms of autism are present very earlier on, and we are, as pediatricians, are perfectly positioned to pick up these early symptoms because we follow up these children right from their birth onwards and in well baby clinic, etc. So last session we had discussed as to what at 3 months, 6 months, 9 months, 1 year, how do up to 2 and 3 years, how do we pick up the various symptoms of autism. And as we discussed in the last session, that usually the symptoms are of, yes, I hope my presentation begins. Yeah. So as we discussed in the previous sessions, that the symptoms of autism are present before 3 years of age. Slides are not visible. I will try again. Sorry for the issue. Let me open this again. Should we begin with a slide? Should we begin with a video in that case?
Yes, ma'am. Ma'am, can you upload
Yeah.
the PPT? Is it there any problem, or you can share the PPT with me? I can
I will.
upload.
Yeah, I will email you the PPT, and
Huh,
then
sure.
is that okay? In the meanwhile, I'm sorry for
Yes,
this
yes.
technical issue. What we will do is that we'll begin with the video. This is a video on how a regressive form of autism. So, this is an interesting video for everyone to watch. I hope that is not a problem for. Yeah. Can you see this? Yeah.
My name is Pop.
Mama.
What, you gonna shoot me?
One, two, three. Splish splash, I was taking a bath. Long about a Saturday night. Yeah. Just relaxing in the dark. Thinking it.
Good morning. Good morning. Polly. Peekaboo. There's Polly. Yay. 1, 2, 3. Here comes mommy. Roar. Here comes mommy. Roar. I'm gonna get you. Roar. Here comes mommy. Here it comes. Roar. Roar. I'm gonna get you, Polly. Ah. Roar. Yay! Bah! 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 What you doing?
He's doing his thing with moving everything in the
Are you organizing, practicing? He's like, this is my corner. No one goes in my corner. Okay? No one touches my things.
Hey, look. Paul.
Polly. Say woof.
Ooh. Ready?
Go, Polly, go.
Ready? Jump. Oh, good job. Ready? Jump.
Polly.
Mine.
1, 2, 3. Here comes mommy.
See, mommy. Bye-bye, mommy. Bye-bye, mommy.
You what? Did you really think you could protect yourself? It's not protection from you. I had made up my back. You stand alone and defy me. I'm not allowed. And they know. They would be desperate enough for that.
So you saw in this video that this child had a normal development in terms of language communication, and later on the child regressed. So the regressive form of autism is a little uncommon. It occurs in only about 20 to 30% of the cases. And the reason why we need to know in the history whether it is a regressive form is that, you know, despite, and you saw this in this slide also, that the response to therapy is not as good versus a non regressive form of autism. So, when we have this kind of autism, we can give a guarded kind of a response to the prognosis to the parents. So in this video, you saw that Paul had a normal development in terms of language communication right up to date, and it was only at the period of 16 to 18 months that the regression happened slowly, first in terms of his communication, social skills, and later on language. And if you noticed, you saw that earlier there was response to name. He was looking at the mother. There was an interactive gaze, and he was laughing, smiling, etc. But later on, what happened was that he did not respond to his name. The mother is interacting with him, but there was no response. And he had this repetitive kind of behaviors wherein he kept on putting his things, his toys behind him. And he had a sensory also issue where he was jumping and bouncing on the couch. So this video typically depicts how the autism regresses, and it shows the development in a child which is right from his birth age to up to 2 to 3 years. Now, as I said again, that autism, if it is there earlier, if you pick up before 3 years, then the response to therapy is much better. Kuntala, is the PPT opening up, or should I start with another video?
Ma'am, still now we haven't yet something, maybe internet issues is going on.
Okay, okay.
Yeah,
So
yeah.
what we will do is I will now show another video. This video I want a little more interaction from the audience, and I'll play this video and we'll wait for about 5 seconds, and then the audience can someone can tell me that what this video depicts. The typical these are some signs. Okay.
मस्त बहुत मस्त है
अरे वाह पकड़ो
So Kuntala, is there any response as to? So I want to ask the audience. So question for the audience: what are the typical signs that one sees in communication and language in this child? What are you seeing? That what is the? So this video is taken in a therapy center. This is Arban. He's a 1.5-year-old, and this is part of the ADOS diagnostic work test that we do in children for diagnosis of autism. So this is a child which is less than 3 years of age, and the kit has multiple components to it. So in this, we are trying to see what is the imitation skill of the child, and we give certain toys to the child and try to elicit the language, the communication skills of the child. So if Kuntala could replay the video again, and I could have some comments from the audience, that what are the typical signs that you see. First of all, is this a normal child? Is this a neurotypical child, or is this a neuroatypical child? Is the response that I expect. Is there any response?
Doctor, can you see any response?
I can't see in the chat box.
Yeah. So should I play the video again, ma'am?
Yeah. That would be nice. Yeah.
अरे वाह अरे वाह मस्त बहुत मस्त है
अरे वाह कपड़ा
Yeah. Any response from the audience? Do you think that this is a neurotypical child, or it is a neuroatypical child? So this is a neurotypical child. Arman is a neurotypical child, and we have done this test to demonstrate the normal social and language and communication skills. So in this, the therapist, you can see that she's trying to blow bubbles, and so initially he's a little hesitant, but when he sees the toy, he comes to her. He
Ma'am,
has, yes,
there is a question from Dr. Meera.
yes,
She is asking, imitating skills present. Child is having eye contact also. So,
excellent. Yeah,
Prutaksha, Dr. Prutaksha is also there. He has a
excellent.
comment.
Yeah,
Neurotypical, but
very
we
good,
don't
excellent.
know about his speech. So he is
Right,
asking about
right.
speech.
Yes. So Arman was speech delay, very well pick up, doctor. But he was referred to us for a suspicion of autism, uh, at 1.5 years. But when we did the EDOS, we found that his communication and his understanding was very good. So that is typically a very well pick up. So he had imitative skills. He had this interactive gaze, and but he was not asking for. It was only that if you notice, he's pointing and gesturing for asking for needs. So excellent. So we wanted to demonstrate, and in the further videos you will see that similar thing in a child of 1.5 years of age, how he will respond if there is autism. So if the PPT is, can we do the next video? And this again, I would like to have an audience interaction.
Ma'am,
Whether
should
this
I
is
upload the PPT or should I start the video?
so I will put up a second video and then we can upload the PPT. Yeah.
Sure, sure,
So
ma'am.
again, in this video, I would like an audience participation to tell me whether this is a neurotypical child or a neuroatypical child. No. Kuntala, can we stop this, please? Yeah. Sorry. I think the previous video played. Sorry about this. So, is this? Is there a video which is playing?
No, ma'am.
No. Okay. So let's go to the PPT then, Kuntala, because apparently we cannot share more than 2 videos.
Right.
Ma'am, there is a response from Dr.
Yeah.
Ketki, Rahul
Yes.
Gaves.
Yeah.
He's commenting on previous video that proto-imperative pointing is present. She was
Right.
commenting on
Absolutely. Absolutely correct. Absolutely correct. Great. And proto imperative pointing generally comes by 10 months of age, and it should definitely come by a year or a year and a half. And it is a prerequisite. So proto imperative pointing is where you hide an object and you ask, see whether the child remembers whether the child has hidden the object and can point out. And it is a prerequisite for joint attention, which is a very important skill which we discussed in the last session. And the reason that joint attention is so important is because joint attention is again a prerequisite for imitative skills. We as humans in our world, we learn through imitation. So joint attention is very important for imitation. In fact, world over, the pioneering center, which since the last 20-25 years has been working on autism therapy in Florida, UCLA, they have a program which is known as Jasper, which is Joint Attention Intervention Program. So they really see whether the child's joint attention is developed or not, because if joint attention comes, then imitation comes. So as in all steps of milestones in development, we know that one step then leads to the second step, then to the third step. So as we discussed, that these are the prerequisites. So Kuntala, can we have the presentation, please?
Yes, ma'am.
Sure.
Ma'am, is it visible?
Yes, it is. Can we have
Yes.
the next slide, please?
Yeah.
Yeah. So as we learned from the previous session, that autism is a neurodevelopmental disorder with difficulty in social interaction, in communication, and some repetitive behaviors. In the first video that we played of Paul, there was a difficulty in social interaction, communication, and there was definitely a repetitive behavior. And as we said earlier, that these symptoms usually appear before 3 years of age. Now, autism is almost always associated with comorbidities, right? In Paul's case, if you notice that he was jumping on the couch, so the association of this was he had a sensory symptom or sensory processing disorder association where he was vestibular seeking. So we discussed in the previous session that there are different types of sensory seeking behaviors. It could be visual, touch, taste, smell, vestibular, or proprioceptive. So in Paul's case, or which we saw the child in the first video, he was jumping up and down and he was pushing his toys all behind him. Now that is again a type of repetitive kind of a behavior, which could be because of his sensory issues, or it could be even a pure repetitive kind of a behavior. Could I have the next slide, please? Yeah, so just to have an overview and to discuss a little more on detail before we go to the screening test which is applied in autism. Uh, Autism, as we know, is a triad in which the social interaction, communication is impaired, and the child could have repetitive behaviors. So the first thing is the social interaction. Okay, in terms of social interaction, the child will not is more object focused rather than human focused. We live in as we discussed earlier on also, we live in a social world, so our interaction should be more towards human, like we are attracted toward humans rather than inanimate objects. These children are more interested and attracted toward inanimate objects. So there you will notice that there will be no eye contact. And even before eye contact, like we saw in Arman's case, the second video where the child was neurotypical, he was pointing out. Even though there was no language, as the one doctor noticed, there was no expressive language, but still pointing was present. So, as in every milestone, as we have been trained, like say a child is not standing, then we go, beyond. Is the child, if the child is not walking, is he standing independently? Is he sitting? Does he have neck holding? Does he have truncal control? Similarly, in language social domain, we go behind. If there is no speech or there is no expressive language, does the child understand? Is there a receptive language, as we call it? If the child does not make eye contact, is the child pointing to communicate his need? So in these children, they may not make eye contact, they may not point out to things. There is no response to name. And you saw that in the first video. Whereas you saw it very clear cut in the second video when the therapist called out to Arman his name, he looked immediately at her and he looked at the object, which is a joint gaze which he had, and there was a response to name and to his name as well as to other people's voices. In children with autism, despite calling out their name, they may not respond. So how many times does one really call out their name? So it is about 3 times that you call out to the child, because when the child comes to your clinic, it is an unusual environment to them. He may be fascinated by the table, by say some kind of toys which you keep, is routinely kept in the clinic. So his attention may not be there. So how do you call out to the child his name? You should always have a gaze which is parallel. That means at eye level, where the child is sitting, supposing the child is sitting on a chair, you just bend down and look into his eye and then call out to his name. So 3 times if you call out and the child does not respond, then you should ask the mother to just make the child sit in her lap and turn his face towards you. Then you call out to the child again, and this you should do twice. Then still, if the child is say interested in the surroundings and not responding, then ask the mother to gently tap his face and turn his face towards you, so like a directed gaze. Then call out to the name. And if there is still no response to the name, then there we could observe or make a point in your notes that probably there is no response to a name. I typically like to see the child again before I say that there is no response to a name, because as we know that we deal with young children less than 5 years, and they've been coming to the clinic, they have a little phobia of the doctors. They think the doctor is giving injections. So first they start with crying, screaming, etc. So for them to settle down itself takes some time. So before we just rush on, but this is the kind of steps that we undergo before we say there is no response to name. Again, their child may not play with other children or may not seem interested in them, and he's in his own world. So you can see in this picture here that that a child, there are this group of people are there, and this child is all alone and aloof. In terms of communication problem, as I spoke already, that the child can have delayed speech or language or a deviancy type. There could be echolalia present, etc. And the child again has difficulty in understanding what others are saying. So in autism, typically you will have receptive language also affected as well as expressive language. Receptive language, as we saw in the first video, the child doesn't understand or will not follow commands or say request which the parent is doing. Not only he does not talk, but he doesn't even understand the words. Going on, as we said, that autism, as we know that autism is a spectrum problem. So there are certain children who will talk, but they will have difficulty talking in whole sentences, in narrative form of speech. So they have difficulty in expressing themselves completely. Now, coming on to repetitive behaviors, the child may have repetitive behaviors such as hand flapping or rocking. And you saw this rocking behavior in the first video. As a child becomes older, the child may have just specific interest. or hobbies. So, if there is a discussion happening about cars or something, and the child is fixated on cars, then the child will just keep on talking about cars. So the other children become a little bit disinterested because they want to move on to the next topic of, say, exams or something like that, or say movies of their interest, but this child will keep on talking about cars itself. Okay, so they have restricted and typical restricted interest or hobbies, and again they have a very rigid kind of a program, daily schedule, and they become very upset if there is a change in their routine. Can I have the next slide, please? So these are some suspicious signs of autism. And as I said again, that before 3 years, these symptoms are present. And if we pick them up before 3 years and we initiate therapy, the outcomes are much better. In fact, the child can be mainstreamed in the community, in the school. And sometimes when I've followed up these children, even I suspect whether I have ever diagnosed these children with autism, because with good intervention, scientific therapies, they do really well. So this is some suspicion signs of autism, which I would like all of you all to take a snapshot if possible and put them up in your clinic. Because we always have growth charts and developmental motor milestones in our clinic, but these are equally important, especially in today's era where we are so much hooked on to, or our children are so much hooked on to media, right? So if there is no babbling at 1 month of age, if there is no pointing, so no gesturing, no sharing of interest or engaging with the parent by 1 year of age, no words by 16 months of age, no two-word meaningful phrase. So two words means ma pani, ma khana. Okay, so these are the ya khana do. So these are two words that the child will speak. By 2 years of age, it should these phrase should come. Now, certain children with autism will just imitate or repeat what the parent has said. So the parents say, "Arman khana chahiye." So that is not a so that though the child in talking is talking in two-word phrases, that is not a meaningful language, and it cannot be counted that the child has good two-word phrases, because this is imitation and this is also known as immediate echolalia. If there is any loss of speech, babbling, or social skills at any age, which you saw in Paul in the first video, it is definitely a red flag sign of autism. And as I mentioned, if there is any regression, it is usually in therapy, it is a difficult to treat, or you need a little more intense therapy. So our role as pediatrician is that we should tell the parents to stay put and continue with the therapy. And already that if there is a regression form of autism coming to you in the clinic, that this child will require little more counseling and little more. This is not going to be a very smooth road for this child. Can I have the next slide, please? So again, to reiterate, that symptoms generally appear before 3 years. It is only that when the parents get alerted to it, or say the child goes to a preschool or a pre-group, or during primary school, when the school teacher points out that there is something different, that the child comes to us. If we were to only educate the parent about these language communication milestones, I'm sure our pickup rate for autism would be much higher. So, as I said, there is no response to name if there are no meaningful words by 1.5 year of age. It is important to see how the child plays with the toys. So sometimes if the OPD is busy, what I usually do is I ask them for short videos, about 30-second videos, or these 1 minute videos that you saw, to show to which are taken with the child with playing with his toys alone with the mother and in the garden, to see how he's playing or how he's interacting with his peers. Echolalia, as I said, that if the child just says "Mummy pani do," if the mother asks "Arman pani chahiye," and he will say "Pani chahiye." So if he repeating again and again, it is not counted as a form of language. It is a deviancy of language, and this is known as immediate echolalia. You also have something which is known as delayed echolalia, which I see in children a little older, about 3 years or 4 years, when the language is just coming in. So In 3 years or 4 years, what in delayed echolalia happens is that they have, they're watching television or they've heard their parents talk something, and they are, if you are, the conversation is about, say, khana. Okay, if you are asking Arman, khana chahiye kya, he will say nahi, and then he will repeat something which he out, and she will say roti sabji chahiye ya juice do. Then he will instead of answering to her directly, he will repeat something which is heard in the previous conversation, the previous day, the previous week, etc. So this is known as delayed echolalia or scripted speech. They have fixed patterns of interest on activities, and we saw that repetitive behaviors in the first video. They can appear to be very hyperactive, and that is, and they can have toe walking, and these are part of their sensory symptoms. So if they have increased tactile sensitivity or touch sensitivity, you can see that these children, the minute they're coming in the clinic, it is almost difficult to hold. Your receptionist or somebody outside the clinic will say, Doctor Saab, isko jaldi dekh lo, ye bahut dhoom macha raha hai bahar. So the minute you open the door, the child comes in, he'll be touching things, and he will, jumping up and down the couch, etc. Or when he walks in, he will come in a toe walking type of a fashion. Can I have the next slide, please? Can I have the next slide, please? Yeah, so this was the first video, and we saw the first video. This video was going to be of Arman. The second video. Can I have the next slide? Yeah. Now coming to early warning signs of autism, and now we will go through a case for how to do the screening for autism. And why this case, again, I'm harping again and again, is that we have seen that really that if we pick up the children early and we do evidence-based interventions, then the outcomes are much better. Usually, when the children are picked up early, so as I was telling in the last session also, the earliest child that I have picked up is which the parent has suspected was of 15 months of age, and it has been my understanding, being in this field for more than 1.5 decade, is that the earlier the pickup is, usually the symptoms are more severe. So these children are usually more severe. Uh, and this child, which I saw at 15 months of age, had there was no interactive gaze present, and the child had no language. He was very irritable, kept on crying all the time, etc. And we did therapies in him, and I see him at 5 years or 6 years of age now, and his autism symptoms still persist. Though from the severe grade, he has now gone to the moderate to mild kind of symptoms. So, as I said, that autism is a spectrum. So, you could pick up children even as late as 12, 14 years of age, where these children are in their, especially in boys, where these children are in their own world, and parents have really not noticed with today's lifestyle, etc. They are concerned that academically he's doing okay, but slowly as they entered into adolescence, and if the teacher realizes that there is something amiss because the child is not moving in a group and he prefers to be alone, or when he gets very anxious, then he's rocking himself in the classroom, or he is smiling to himself or laughing to himself. So the symptoms can worsen a little bit when they enter adolescence, and it is important to screen once if you suspect autism early through the MChat and other tools that we will discuss later on. Then it is important to screen them and to evaluate them further with a diagnosis, and to put them in therapy. And the role of pediatrician is the central and key to it, because the child, you have such a great rapport with this child, which is built up since birth, and they really seek your advice out very intensely. And it is just important to tell the families that you stay put and continue with the therapy. Of course, it is also important that you ask the therapy center that you refer to, that every 3 monthly they have to give you a documented response in terms of a report, that how the child was and what the child is doing after 3 months, what were the goals of therapy, and how many goals have been achieved. Okay, next slide, please. Can I have the next slide, please? Yeah, so this was the third video of ball that we played on. And if you notice that in 2-year-old child, we would like that the child uses language for communication purpose and not just repetition, which is seen in echolalia. So in that form, the child just uses language with a repetition. There is no interaction. It is not used for communicative purposes. Again, in receptive language, you expect a 2-year-old to at least understand 50 words, to speak spontaneously, to use words, if not sentences, to convey his needs and his wishes, his emotions to others. The speech should be more directed towards others. He should be able to put at least two words together to form phrases. He learns words very quickly. Again, during when the language is emerging, he repeats certain words. So that is not counted. That almost seems like echolalia, but it is not echolalia. So how do we one differentiates between echolalia? So this is one important clue that I found in my clinic. What I do is that I ask the parent कि वापस बात करता है क्या, जो आपने बोला वो रिपीट करता है क्या. So they will say हाँ रिपीट करता है. So I will ask them, आपने अगर पूछा अरमान आपको दूध चाहिए, so does he ask, आप क्या अरमान क्या रिपीट करेगा. So then they, if so there is two scenarios. So if the parent says that अरमान अगर वो रिपीट ऐसे करता है कि अरमान आपको दूध चाहिए क्या, versus say if he says अरमान दूध चाहिए क्या and smiles, then it is a totally different meaning. So the second is what a neurotypical child will do. And the first one is what a child suspected with autism will do. In other words, if the echolalia is similar in tone and a tone and words of what the parent repeated, then, and this is happening persistently, then the suspicion of autism is more in them. So children in this age between 2 to 3 years, just they are playing with words. Just as they play with toys, they also like to roll the words on their tongue and they play with words. So they tend to repeat. But if it is in the same prosody, or as I said, in the same tone as a parent, without the child understanding what he's saying, then definitely there is a suspicion of autism. Can we have the next slide, please? Can we have, yeah. So these are some screening tools in the clinic. First is, of course, the MChat. I'm sure most of you are familiar with the MChat because in a lot of webinars and sessions, thankfully, MChat is now widely used. So MChat stands for Modified Checklist for Autism in Toddlers. It is a US-based tool, but it has translation in multiple English, in Indian languages also. So once if you screen in your, and it takes just few minutes, it is a parent derived questionnaire. I will show you in the next slides how it looks like, how it has to be administered, and we also have a video where one of the doctors has administered the MChat, and we can see in real time how it looks like when it is administered. So once the child comes positive for MChat, we have to do a follow-up MChat. Repeat the MChat within a 1 month's time and see. And if the child is moderate risk for autism still in the follow-up tool, MChat, then we definitely have to refer him to a developmental pediatrician or a neurologist to do a diagnostic tool for autism. So these are some of the diagnostic tools for autism which we use very regularly in the Indian scenario. The DSM-5 criteria for autism, where there are 4 divisions, A1, A2, A3 given, and we also not only look at whether your child is coming on the DSM-5 criteria positive for autism, but also the severity of autism can be roughly come to a conclusion on the DSM-5. The second is the AIMS modified autism inclin tool. Earlier it was the inclin ASD tool, but about 3 or 4 years ago, the AIMS hospital in New Delhi modified to suit it to the DSM-5 criteria. Earlier, the inclin ASD tool was based on the old DSM-4 criteria. It has now been upgraded by the AIMS team to suit as per the DSM-5 criteria. And the best part of this is that they have come up with an app. So if you put it in the Google Store, earlier the app was available for Android only, but now it is available even for the iPhone users. So if you put it on the Google Store in the Play Store and you you put pneuroaims.com, then you will get a lot of tools for you will get these tools. Or even if you put aims modified ast incline tool, you search it, then this tool can be downloaded. It is like an app which can come on your mobile, and you can do it on OPD basis also. Then the fourth tool that I would like to talk about is the Indian Scale for Autism Assessment. So this is a quantifying tool. uh, the government of India has come out with a statement in 2016-17 that AIMS modified incline tool should be used for diagnosis of autism and for quantification purposes, like to know what is the percentage of autism. The ISA tool has to be used. Both these tools are used in government setups and with the NGOs and the non-government setup as well as the government setup for certifying of autism, because autism is now part of the act, the Disability Act, and there are certain benefits which come with autism. Even certain patients whose parents are working in central government services, there could be reimbursements possible to them if they are spending the money on therapy. Hence, the need to know these tools are which are present in India and aware. The other tool which I have not mentioned, but you saw in Arman's case or the second neuro video of a neurotypical child, is the ADOS that I mentioned, the Autism Diagnostic Observation Schedule. This is worldwide use, and it is a standard schedule used worldwide for diagnosis of autism. This tool consists of multiple toys, and we observe the child, we rate the child, and then arrive to a diagnosis. And it takes almost a period of 1.5 hours to 2 hours for the ADOS to be administered. So in India, it is done mostly in institutes, for research purposes, or when say you need to get data in trials, etc. It is used more for that. Can I have the next slide, please? So now we will see more about the MChat, because that is what important to us in the clinic. So as I said, the MChat is freely available. We don't need to pay for it. It is easily downloadable. It is a questionnaire which has to be done by parents. And the age for screening is 16 to 30 months. Please note this age, 16 to 30 months only. So if you have a 4-year-old coming or a 5-year-old coming with suspected autism, the MChat cannot be administered. Generally, I have parents coming as young as 10 months or 11 months or 1 year to me for suspect autism. Or even in one, it has been my experience that in younger children, less than 2 years of age, so less than 24 months, the MChat, I prefer to repeat it before I say that the child is a moderate or a high risk for autism. So this is just one personal experience which I would like to share. Now the time typically taken is 10 minutes. So if you have a child which is suspect, we can also Google it, and the parent can fill it online and give a printout to you, or you can have your receptionist take out a few prints and keep with her. And if the child is suspected, then you can ask them to wait outside and fill it out and get you the filled version, so you can score it. It is a pretty very simple scoring procedure, and it just based on yes, no, or pass or fail item. So as I said, if the child screens positive, then generally, unless it is a high risk, so there are three categories in this: whether the child is not at risk, moderate risk, or high risk. It has been my experience that high risk, when it scores high risk, there is definitely almost always a suspicion that there is autism present. And instead of asking them to come for a follow-up interview, I would recommend that you send them to a subspecialist or super specialist for a diagnostic uh, test, like say a DSM-5 for confirmation of diagnosis. So therapy can be initiated immediately because the critical time for therapy in autism is 0 to 5 years of age. Beyond 5 years, it becomes a little tough because different type of behavior set in. So therapy is not very smooth beyond that particular age. So the earlier that you diagnose and put them for therapy, the better it is. In fact, I would say that diagnosis of autism is almost like a medical emergency in OPD practice because they need to be going to the therapy and doing the therapy very properly and in a proper evidence-based manner. So just sharing you that this is a screen. This is how the MChat looks like. And if you want, you could please take a screenshot. And if you just put this on the website, you will get DMs and chat. Could I have the next slide, please? So it was in 2009 that the MChat came up and by Robbins, and 2013 there has been a revision done, which we will see in the next slide. Can I have the next slide, please? Yeah. So it is a set of 20 questions where the answers are yes or no. And again, it is available in Hindi in two versions. So one is a very pure Hindi, and one is a little colloquial kind of a Hindi, which we will see in the following slides. It is also available in Marathi, Punjabi, Tamil, Telugu, Urdu languages. In fact, the MChat people, look out for more translations. So in case if you're keen for a translation, the MChat can be translated in Gujarati and other languages. If people come forward and want to translate, you just have to write to them that yes, you wish to translate it, and be translated, and send them the translated version. And if they approve, then it will be visible for everyone and to use in that language for globally all over the world. So again, to reiterate, remember that the screening age is only 6 to 30 months. And let us go through these questions one by one. So if you see that what we usually ask is, we ask how the child usually behaves. Okay, so it is not like एक बारी behave किया तो फिर you take yes or no. Usual मतलब महीने में कितने बार ये ऐसे करता है. So sometimes few of the parents have noticed कि they go into a block when answering these questions. तो मैं I tell them that आप घर पे लेके जाइए, आराम से आप fill कीजिए. Sometimes I also tell them that you get multiple people to fill in. So in Mumbai, most of the parents are working, and sometimes a child is in the daycare or say at some other, there is another caregiver. So I ask them, let the mother, father, the other caregiver, they also fill in. The more responses you get, the better it is, because your suspicion becomes more stronger. So so let us look through briefly the questions. So does the first question is, does a child point out to something across the room? And if you notice in this, they've also given you an example. So does a child point to a toy or an animal, or does a child look at the toy or animal? So it is more about the receptive language, which is which is discussed in this question. Then the next question is, does a child appear to you to be deaf? How does the child play? Does a child pretend play, make believe? Matlab, does he use like a stick, or say he just uses a book and puts him to its ear and say that as if he's talking to the phone? Does a child play with the doll, and then as you feed the child is imitating the same behavior with the doll and trying to feed the doll? So does the child do that? Is the child very hyperactive and climbing on things? So does he have a sensory element to that? Does the child have any unusual finger movements? So I have seen generally these children, they do these kind of movements near their eyes, and they're looking at it, or they will look at this bit from the corner of the eye. So is that the behavior that is seen? Does the child point out to with one finger? So again, in gesturing, there is different levels of gesturing which are present, and there is descriptive gesturing, there is instructional gesturing. Descriptive matlab, if you will ask him आपको कितना बड़ा खिलौना चाहिए, he will say big. Okay, then instructional में अगर पूछा कि आपने कि doll के fan किधर है, and if he points out, if he points with one finger, so that is more mature versus him pointing up with the whole hand of it like this. All right. So you come to know the maturity of the child. So these are all important cues for the therapist who are training them. Yeah, or who are undergoing do therapy for them, because they know कि which level the child is functioning in terms of the age, और कौन से level पे उसको goal, when they are making the goals, कौन से level तक उसको goal उसका complete करना है. So does the child point out, is the child interested in other children? So can I have the next slide please? So does the child show you things? And so this is shared enjoyment, which we see commonly in neurotypical children. They'll come to you with a toy, they want to share with the parent, they will make an eye contact and try and engage the parent. The other question is whether the child responds to you by name, whether the child smiles at you and smiles back, does he get upset with everyday noises. So even a routine mixer ka awaj, yeah, some music which is going on in Ganpati festival or something like that, or routine music which you put on, the child will just clamp his ears. Now, this is not like typical only of autism. Anyone who's auditory hypersensitive may have these things. I've seen children also with ADHD having these sensory issues. There could be sometimes, as we said, comorbidities present in autism. So there could be a motor component. So does a child walk? Does a child look into your eyes when you're dressing, undressing? Does a child try to copy or imitate you verbally, making a funny song, then looking at you, etc.? Does the child look and turn to the head to look at something? Does the child try to watch you, etc.? And does he come and show you things and watch your face when he hears a funny song or something like that? And does he likes to have excessive movement? Is he bouncing, etc.? Or as you saw in the first video of the child Paul, where he was rocking. So is there any excessive movement? Can we have the next slide please? So how do we score the MCHAT? So most of these items, if the yes is the regular response or a neurotypical response, and that response you will score as 0. Okay. If there is no response in all these items, then it is a at-risk response, and you will put it as 1 point. The items number 2, 5, 12. 2 was where you asked whether you think that the child is deaf, and 5, 12 were reverse code. Means in them, yes is not a typical response. And if you get a yes response in these, it is an abnormal response, and you will score them as 1. So these are sometimes, in the questionnaire, typically they put these reverse code because बहुत सारे पेशेंट्स या पेरेंट्स कैसे करते हैं, दे विल जस्ट डू टिक टैक टो, यस नो यस नो यस नो करके करते हैं. तो इसलिए ये पकड़ने के लिए इन्होंने ये रिवर्स स्कोरिंग डाला है. So what do? We totally add up the score, and what you submit all the points and you add up what is the risk. So how does one interpret the score? अगर score 0 to 2 है, then you will say there is a negative risk or there is no risk for autism. If the score is 3 to 7, then you say there is a moderate risk for autism. If it is between 8 to 20, it is a high risk for autism. So you re-administer the MCHAT follow-up only for at-risk children. So moderate risk or high risk. And I said that agar 8 to 20 has score of high risk, then I would definitely refer these children to a super specialist or a subspecialist, so that they can confirm the diagnosis by DSM-5 or any other tool that they use, so early therapy can be started, so as to we do not miss out the critical period. So definitely, agar the response is more than 2, you need to refer for early diagnosis and management. Can I have the next slide, please? Yeah. So this is what the follow-up score looks like. And it is typically like what we saw in the MCHAT. Same hai, only pass or fail. Can I have the next slide, please? Next slide, please. Yeah. So again, to reiterate how to go about or interpret the scoring. So low risk, if children are less than 2 years, we would like to screen them again after their second birthday before we say, there is no autism. After, even if there is low risk and the child is young, less than 2 years, do try and give the MCHAT again. If there is medium risk between 3 to 7 years, definitely do a follow up after a 1 month and see whether there could be some times, especially between the 3 to 4 kind of a score, where the child was not in a good mood or something like that, or just woken up from sleep and he has been dragged to the clinic. So again, give him the benefit of doubt. And in high risk, I would uh, yeah, so here also the MCHAT definitely says that we can bypass the follow up and refer immediately for diagnostic evaluation and early intervention services. Next slide, please. Yeah, so autism, the MCHAT can detect autism in toddlers, and it has a very high predictive value, almost 75%. It is well published, well accepted worldwide, and I think you should definitely Google it, download it, take a printout, or your parents who are a little anxious, you can ask them to download and ask them to fill it out and get the score to you. Next slide, please. Yeah. Now coming on, though you do not need to know this, but in case if you go and you are comfortable with downloading the app, which is available from the AIMS website, this is how the AIMS Inclin diagnostic tool looks like, and it covers the entire spectrum of autism, right from autism, classic autism, to Rett syndrome, to Asperger's syndrome. It is the primary caregiver must be present. So it is very nice in our Indian setting where it is to be administered by the doctor in the presence of the primary caregiver, the mother and the father, and the doctor also observes the child. So sometimes the child is hyperactive, moving all over the clinic. You are seeing it, the parent is seeing it, and the whole clinic staff is also seeing, but still the parent will say नहीं हाइपर नहीं है, एक जगह पे बैठता है, डॉक्टर साहब सिर्फ आपके क्लिनिक पे आए, अभी कर रहा है, अभी कर रहा है, whereas the receptionist is saying outside also he was doing the same thing. So your observation, if the child is hyperactive or for any other point is in difference with the parent, you are the chief person as per the incline tool, and you have to mark them as hyperactive, though the parent deny it. And you ask for the behavior, what is the behavior most of the time, and the questions are very simple in this. There are in Hindi as well as English format, and you can use these questions with examples, and they can be repeated and supplemented by observation, and then there is a scoring system. Can I have the next slide, please? Yeah, so this is what the ISA looks like, and this is again it looks at in 6 domains. It is used for certification more in government authorities, by government authorities for certification purposes, because as I said that if there is a cutoff, if you can look down, there is a total score given of what if it is less than 70, it is no autism, and if it is more than 250, then it is definitely a severe autism. Can I have the next slide, please? Yeah, so what I will do at this point is that I will just play one video in which my team has administered MCHAT in Hindi. So let us try and see if this video plays, and then if you
आपको
have
कभी
questions,
ऐसा लगा है कि आपका बच्चा
is this video playing? Oh no.
Ma'am, it's not visible. Yeah.
Not visible, huh? Okay. Let me try, because it just comes and tells me here it is there's a message popping up and saying that only 3 videos can be shared. So let me see if this video plays. If not, we can go through the PPT. Just few. Okay.
आपको कभी ऐसा लगा है कि आपका बच्चा सुन नहीं सकता? क्या आपके बच्चे को चीजों पर चढ़ना पसंद है, जैसे फर्नीचर?
Is that video playing?
No, ma'am.
No. Okay, let's
It's
go
not
to the PPT
visible.
then. Yeah. Let's go to the PPT then. Yeah.
Yeah.
In the meanwhile, are there any questions?
No, ma'am.
Okay, let's go to the PPT, please. Yeah. Go beyond. Next slide, please. Next slide. Next slide. Yeah. So this is how the Hindi MChat looks like. And in this child, we found that the child had nahi in almost 6 questions. Next slide, please. Next slide. So the total score in this child was 6, and he was moderate risk for autism. And we have called this child again after a month. So in the month, 1 month, when the child follows up with us, what we tell the parents is just 2, 3 simple things. We tell them first is take the child totally off social media or any form of television, laptop, mobile, etc. No, absolutely. So the thing is that we are seeing a lot of virtual autism cases, especially post COVID, where the childs were really hooked on to their mobiles and parents were busy. So if there is virtual autism, it has been my experience that if the language does come up, and it comes up eventually, and it becomes plateaus out in about 2 or 3 weeks time. So, if there is no mobile and no media given to the child, then whatever language is there because of the media, excessive media use, it will emerge and it plateaus off in 2 to 3 weeks' time. So, we are giving that kind of time on follow up. That is why we call them for a follow up after a month. So, one is, of course, no media, laptop, and etc. You ask the parents instead to engage the child in games, in toys, or in even daily chores or whatever. Like, अगर किचन में है तो give him some plate to put, और बर्तन हुए हैं to put him, tell him कि आप कपड़े से पोंछ लो, and put them back in its place, etc. So he's engaged with the mom in her daily activities. Or when the child is also playing, the mother, we generally and the third thing that we tell them is do parallel talk. So what we mean by parallel talk is that when the child is playing, the uh, as we said in the clinic, when you're looking out for response to name, it should be at the same level. The eye gaze of the child should be at your level. So we tell the parent ki baith ke khelo bacche ke sath. So the child, the mother is not sitting on the couch and child is sitting down. ऐसा नहीं खेलना है, उसके level पे खेलना है खिलौनों के साथ. And introduce only one toy. If you give them 2, 3 toys, then they go like a little. They want this, that, etc. तो बाकी के खिलौने be at the reach of the mother, but cover them up. Play at the on the floor at the child's eye contact level, and introduce one toy. And when you're introducing, supposing you're playing with a simple car, कि you talk about the car, कि अरमान ये गाड़ी है, ये गाड़ी के पहिए है, ये लाल कलर की गाड़ी है, ये ऐसे जाती है. So the mother talks, or whoever is the caregiver, and all the family member talk to the child. So giving almost like words to the child to talk. So these 3 things have to be done at the parental level, at the home level, and the parent. And the fourth thing is I encourage them to read books to the child, simple books or to the child, and so all, or storytelling, singing songs, etc. So all these 4 things we can do definitely at home level. Call the child up, call the child later after a month for a follow up MChat, and then decide whether the child still falls in the moderate uh, risk thing. And if it is there, then we refer again to a specialist, subspecialist, for a confirmation of the autism diagnosis and put them in therapy. So thank you, and I'm open for any questions.
So, ma'am, there are no questions. I can see.
Yeah. So sorry about that initial hiccup about the
No,
PPT
ma'am.
opening. Yeah. So if it is, there are no questions, should we call it a day or should we
We
wait for
will
one
wait
minute?
for 1 minute and then we'll.
Okay, no problem, no problem. Yeah. Should I try and see if the PPT is opening?
Yes,
If the video is opening?
आपको कभी ऐसा लगा है कि आपका बच्चा सुन नहीं सकता? क्या आप
yes, ma'am. We can see now.
No, this is the first video. That other video is not opening of the M chat. I think it takes only 2 videos.
Are there any questions, doctor?
No, no, ma'am. No, ma'am. Kuntala, no questions. Ma'am, thank you very much for very informative session with demonstrations. So this will be very useful for the young pediatricians who have just started practice. So they will learn to screen the patients easily with your even few signs and few sentences, means few pointing, speech, like that. If there is no pointing at 18 months, then so these are the very simple signs you have given. Then so thank you very much, ma'am.
Thank you. Good night.
There is
Thank you,
one
ma'am.
question, ma'am. Just one.
Yeah, yeah.
Doctor Kisley Naik. So he is asking about the drug therapy, any ma'am, for brain-oriented nutritional therapy. So is there a brain-oriented nutritional therapy?
So nutrition is very essential for the brain and brain nutrients. But for autism specifically, there have been lot of trials, but there has been no definite nutrient deficiency which has been linked to it. So along with our therapy, and sometimes if there are any challenging behaviors other than atypical antipsychotics, we do advise for say vitamin D testing, and the vitamin D levels, B12 levels, etc. are low, then supplementation can be done along with the general nutrition and other supplementation.
Okay, ma'am.
Yeah.
There is again a request from Dr. Rakesh Kumar. He's asking
Yes.
for the video and PPT. Your videos.
Yeah, so that I'm sure you guys can help. I believe there is a recording which will be available, so then Dr.
Yes,
Kumar
ma'am.
can access
You
to
can
it.
share the recording with them.
Yes, definitely. Yeah, definitely.
So that's all, ma'am. Thank you very much.
Yeah, thank you so much. Yeah, thank you. Good night.
Thank you, ma'am. Thank you so much. Good
Thank you.
night.
Good night. Good night.
Good night, ma'am. Thank you, Sumaya. Thank you, Kuntala.
Thank you so much, sir.